Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you Canada's brightest minds in emergency medicine from EMC Studios in Toronto. EM Cases is part of SREMI, Schwartz-Reisman Emergency Medicine Institute, the nonprofit organization dedicated to improving EM care through research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
This recent fall and winter, we're seeing a huge rise in pediatric respiratory illness. This was totally predictable. And in fact, Sarah Reed did an EM Quick Hit a few months back where she warned us of the upcoming tsunami of coughing kids. There are many viruses around: RSV, COVID, influenza, parainfluenza, enterovirus, adenovirus. In Canada, we've seen an early RSV surge in the 0 to 5-year-old age group especially, so lots more bronchiolitis. Influenza A is far above expected levels as well, generally the 5 to 11-year-old age group. So this is a perfect time to brush up on our approach to the child with acute respiratory illness, and in particular, the evidence-based management of bronchiolitis. It's my pleasure to have on the show, as part of our Best of the University of Toronto Emergency Medicine series, world-renowned researcher on bronchiolitis, pediatric emergency physician at the Hospital for Sick Children in Toronto, Dr. Suzanne Schuh. Welcome, Dr. Schuh.
Thank you, Anton. Thank you for having me here. It's a pleasure to talk about bronchiolitis.
There's so much to talk about. Let's start off with a case or two, shall we?
Sure.
A 4-month-old male who presents to your ED with a first episode of respiratory distress for 24 hours. The child has had URI symptoms for the last 2 days. They're alert. They're well hydrated. The vitals are the following: a respiratory rate of 50, heart rate of 130, temperature of 38 degrees Celsius, and an oxygen saturation of 94% on room air. There's mild chest retractions, crackles, and wheeze. The child's feeding well in the emergency department, smiling, and follow-up is available in the next day or two. You go to arrange some follow-up for this child, and the nurse alerts you to an alarming oximeter. The oxygen saturation now reads 87% on room air, and the nurse tells you this is while the child was asleep. So the question is, what do you do? And we'll do this as a little multiple choice this time. So A, do you turn off the oximeter, discharge the patient, and have them follow up in the next day or two? Do you wake the boy up, document higher saturation, and then discharge them? Or do you admit them for supplemental oxygen? So I want you to think a little bit about what you would do, A, B, or C there, and we'll have you think about a second case for comparison. So the second case is a 4-month-old boy who comes in with respiratory distress, who has a respiratory rate of 76 and an awake oxygen saturation of 87%. There's nasal flaring, grunting, chest retractions, pretty obvious respiratory distress signs. They're feeding about 25% of normal. There's decreased urine output. So the question here is, again, multiple choice. What is your mode of initial oxygen delivery? Is it A, standard low flow nasal prongs, or B, high flow nasal cannula? So these are just a couple of the things I want you to think about while we have a discussion with Dr. Schuh here. So with the hordes of pediatric patients with respiratory illness that we're seeing these days, I find that sometimes it's difficult to sort out which ones have which illness. And it is complicated. My understanding is that 20% of bronchiolitis is caused by rhinovirus rather than RSV, and that those kids are at risk for asthma. And as we've all seen, there's considerable overlap in the presentation of asthma and bronchiolitis, and of COVID and of pneumonia. So how do you distinguish bronchiolitis from asthma, from bacterial pneumonia, from COVID, et cetera? And does it really matter? Like, what's your practical approach at the beginning, initially, when you see that child, to sort out which illness they have? Because their management's going to change significantly depending on which illness it is.
So yes, this can be a little bit of a confusing issue. So the most important factor with respect to bronchiolitis is the age. So about 95% of cases of bronchiolitis happen in infants under the age of 12 months. The older the child gets, the higher the probability that you are dealing with something else, such as, for example, asthma. So bronchiolitis can happen over the age of 12 months, but it is distinctly uncommon. The other issue has to do with the number of episodes with a bronchiolitis-like phenotype that the child has experienced. The older the child gets and the more bronchiolitis-like phenotype presentations the child has experienced, the more likely it is that you are dealing with something other than bronchiolitis, such as, for example, asthma. Now, we now know that you can actually make a tentative diagnosis of asthma in otherwise healthy children over the age of 12 months. And in a minute, we could talk about why that is actually important.
That's a serious game changer, because I remember the days where we weren't allowed to call it asthma if they were under 4 years old.
Right. That thinking has actually changed several years ago. So there are children that present with wheezing episodes over the age of 12 months that you can actually fairly confidently tell the family that this is likely tentative diagnosis of asthma. And specifically the infants that fit this profile are those that are otherwise healthy. They have had at least one previous episode of wheezing. So this is their second episode. And they are sick enough to actually require therapy in the emergency department. You may also think about this in the context of at least one previous wheezing episode or a presentation to the ED that requires therapy. And if you do deliver that therapy, the child has to convincingly get better. The reason this is important is because preschool wheeze is actually quite a serious matter, or can be quite a serious matter. The reason for this is that there is a subgroup of wheezing preschoolers that have abnormal lung function at the age of 5 or 6 years. And if their inflammation, if the inflammatory process in the lung is not controlled adequately, they can actually end up with abnormal lung growth, and they constitute the population that is at high risk of COPD during their adult years. So this is why we recommend that preschool wheezers who require treatment in the ED, not only should they get corticosteroids in the emergency department, but they should be discharged home on 3 months of inhaled corticosteroids to control the inflammatory process.
Wow. So there's more reason than just making the child feel better to identify asthma early and treat it.
Exactly.
It actually has long-term consequences.
It can have long-term Now, this is a small subgroup. So the majority of these preschool wheezers do get better by the time they go to school. So about 75% improve and the whole thing settles down. But there is a subgroup that does not settle down. And so this does represent overtreatment. Only about a half of these children do respond to inhaled corticosteroids. So it's not a panacea for everybody. And you do not tell the family, therefore, that this is definitely asthma, but we tell them that it's safer to overcall it rather than undercall it, and to overtreat rather than undertreat, which has its challenges because people do not follow, daily medications when the kid is well. So there is a huge educational component to the entire exercise, but it is important to educate the families that it may happen again.
Fascinating. So that's a little bit about distinguishing bronchiolitis from asthma. It is wonderful to hear that we can actually occasionally diagnose asthma in a 1.5-year-old. That's fantastic.
Now, one thing about this whole point is that it's not always possible. So if you have a 9-month-old kid, for example, at the upper end of the bronchiolitis spectrum, and the whole family has asthma, the kid is full of eczema, and so on. There is a strong atopic history in the family, especially if the kid is sick. The question comes up, should I treat this? Should I actually treat this as a first asthma attack? And I think most people would agree that there are some children where you have to give it serious thought that this in fact may be the case. So we cannot always tell one from the other, practically speaking. And if the families ask that, then that's exactly what we tell them.
Fair enough. This one is especially important, the distinction between bronchiolitis or asthma with a URI and pneumonia, bacterial pneumonia,
Yes.
because my understanding is that the data is pretty clear that there's overuse of antibiotics in
Yes.
kids with respiratory illness.
Yes.
How do you make that decision besides the usual, obviously if a kid is toxic and they're in septic shock, that's one thing. So we all know that those kids, require aggressive therapy and they require immediate antibiotics, etc. But for the kids who are kind of in the gray area where you're not sure if they're viral or they're bacterial, what are just some of the things that you do when you're on shift to sort out whether you should give antibiotics or not?
I think it's important that we recognize and accept the fact that kids with bronchiolitis can be febrile. High fever with bronchiolitis is not very common. It can happen. It definitely can happen, but it's not all that common. But just because the child with what looks like a typical bronchiolitis phenotype is febrile would not make me give antibiotics. So first of all, bacterial pneumonia is not very common under the age of 1 year. That's not to say it cannot happen. It does, but it's not very common. And these children, as you've correctly pointed out, have high fever. They look ill. They do not drink. They are miserable. They are toxic, and so on. They may or may not have unilateral chest findings, but there is usually something that tells you that the kid is just not right in terms of bacterial illness. 99% of children with bronchiolitis, even though they may be febrile, they do not exhibit this toxic appearance. So in 99% of children with bronchiolitis, the bacterial infection actually does not even come up in terms of the thought of giving antibiotics. So if you do not have associated otitis media, or there are signs of, as you mentioned, sepsis or toxic appearance or something else, or previous history of recurrent UTIs or something like that, then antibiotics would actually not be part of this. It's something that we would not actually consider, which brings you to we can discuss the chest x-rays and so on related to that particular issue.
Yeah, it does bring up the topic of which kids need x-rays, but
Yes.
I'll keep the listeners waiting for that one because we can talk about that in a little bit. So the difficulty that I've been having with these hordes of children distinguishing between a pretty sick bronchiolitis kid and bacterial pneumonia, it seems like there's no sort of quick, easy magic answer. And really, it's the entire clinical picture put together.
Yes.
Things like high fever, toxic appearance, lack of wheeze, I guess, is one as well. In bacterial pneumonia, it's less likely to have a wheeze.
That's an interesting one. Absolutely, 100%. Yes, I think I should have mentioned that one. Lack of wheeze is definitely one. Yes.
Okay, and again, the unilateral chest findings are just some of the things. And I think just to recognize in yourself that if you're Dr. Schuh, who's been seeing sick children for many, many years and has massive experience, I'm sure that just by standing at the foot of the bed, you can probably tell if they have bacterial pneumonia or not. Whereas if you're in a community hospital that does not see a lot of children, you might need to be a bit more careful about trying to make that distinction. The next question is to do with defining what bronchiolitis is. Because this actually, you'd think that it would be pretty straightforward, but it's not. And this harks back to the first question we asked, is how to distinguish these. It's hard to be able to distinguish asthma from bronchiolitis, from pneumonia, from COVID when we don't even know what the definition is. So let's try and zero in. What is the definition of bronchiolitis?
You're right. This is a very tough question, and I don't want to confuse the listeners any further. But I'm afraid I'm going to have to, because the bronchiolitis definition, it varies depending on where you are and who you talk to. And it also is quite fluid with respect to research on bronchiolitis. So our friends at the American Academy of Pediatrics tell us that this is defined as the first episode of respiratory distress with viral symptoms and associated wheeze in infants under the age of 24 months. On the other hand, our British friends from the British Thoracic Society, they prefer to limit the definition of bronchiolitis to infants under the age of 12 months, especially those that have crackles, and they omit the wheeze components, which is, I think, good, because wheeze is frequently absent in bronchiolitis. I think we have to accept that. And 95% are under the age of 12 months. So this can be quite confusing with respect to management and also with respect to research. What kids do you actually study? So this is quite confusing. The other thing is that recurrent bronchiolitis or bronchiolitis-like phenotype carries with it a very high probability of other entities, as I said before, such as, for example, asthma. So to further confuse the definition is that there is a relatively recent study which points to the fact that bronchiolitis may in fact not be a single disease, that it's basically under an umbrella with the same phenotype, but very different pathophysiologies and very different subsequent risk of asthma. So as you mentioned before, rhinovirus, for example, causes 20% of bronchiolitis. Well, some rhinoviruses carry a risk of up to 60% of subsequent asthma. So not every rhinovirus is the same. There are different subtypes, and it varies. So at the moment, however, we do not have the luxury of knowing what the etiology is, what virus the child has, and we do not know what kind of rhinovirus it is. So we treat them all the same, but that may not be the case in the future in every single kid with bronchiolitis. But at the moment, they are all treated the same.
Okay, so my anxiety about not being able to figure out whether someone has bronchiolitis or asthma or pneumonia is well-founded, because
Yes.
It is quite confusing.
Extremely.
And I think before we move on to talking about x-rays, I just want to highlight the presentation of bronchiolitis in neonates and how that might be different. There's things like apnea and cyanosis.
Yes.
Can you just give us sort of the real world description of what you see at sick kids in terms of the neonates with bronchiolitis?
So yes, that's an interesting point, Anton. Neonates can have bronchiolitis. It's not very common, actually. And part of the problem is that there's always a doubt in your mind. Is this actually truly bronchiolitis? Or is it something else? Because the presentation can be a little bit more subtle. If they have apnea, even then you have to think about other things such as sepsis, etc., etc. So even that is not obvious. So the presentation in neonates can be a little bit more atypical. And obviously you have to be extremely careful in terms of management. So neonates with bronchiolitis, generally speaking, do not go home. They have to be watched very carefully because they can decompensate very easily because they have limited muscle mass. Their energy level is obviously very limited as well, so they can become apneic and they can become very tired. So they need to be appropriately monitored.
All right. Let's talk about x-rays. Now,
yes.
We have all heard that children with bronchiolitis do not need x-rays, generally speaking, because when we x-ray them, we end up seeing, maybe there's a tiny little bit of something there. Maybe there's a local infiltrate there. Maybe not. Let's put them on antibiotics just in case. And of course, that leads to overuse of antibiotics, which of course leads to subsequent increased resistance of antibiotics, the occasional anaphylactic reaction, and a number needed to harm for diarrhea of 11. So we don't want to be overusing antibiotics. Which kids with acute respiratory illness need a chest x-ray in the emergency department?
Right. So there is definitely a subset where you would want to do a chest x-ray, and it is a minority. It is a distinct minority. So first of all, if you suspect another diagnosis, if you have a child that is, for example, failing to thrive, that has had feeding problems, not just at the time of bronchiolitis, but even prior, there may have been choking with feedings or a history of previous recurrent pneumonias, or the child, has a history of it takes half an hour to feed and has to huff and puff in between. So that's a very worrisome. Does the child have something else? So if you suspect that this is not your usual bronchiolitis, I think it's reasonable to do an X-ray. Also, if there is an atypical presentation, so the child has been diagnosed with bronchiolitis and comes back to your ED a month later and is still wheezing, so the median duration of symptoms in bronchiolitis is about 2 weeks. And it's important to tell the family that, by the way, so they don't come back the next day. But if it goes on for a long time and the child is not getting better, then you also want to make sure. If the child is critically ill and you are thinking of, using high flow or sending the kid to ICU, then I think our ICU colleagues would not be very happy if we did not do an X-ray, because they want to make sure also what they are dealing with. You mentioned the neonates previously. That's another situation which may make it reasonable to actually do a film as well. We actually did a study where we did an X-ray on everyone with bronchiolitis. We read it, and the radiologists read it, and we did not do very well because, as you mentioned, we all tend to overread the films. So one radiologist told me an interesting rule of thumb. If you have an airway disease and some airspace disease along with it, the airspace disease does not become bacterial the moment the virus hits the lungs. So that usually, and by no means always, but usually means that the whole thing is of viral origin, which to me makes a lot of sense. Whereas bacterial pneumonia tends to be an isolated lobar consolidation. In that particular study, I mentioned about 20% of the kids actually had airway disease together with airspace disease. So officially they have, quotes, pneumonia, but it's all viral.
Very interesting. Yeah. Was that the study that showed that ED docs overread chest x-rays at a rate of 5 to 1 compared to radiologists?
Yes, that's exactly right. Yes.
Yeah, that's an incredible finding.
Yes. Out of 200, I think there were 260 patients, and out of them 2 had an X-ray that was, quotes, not compatible with bronchiolitis. And even of those 2, one of them was RSV positive and turned out to have bronchiolitis.
And was that at a pediatric emergency department?
That was at Sick Kids.
That was at Sick Kids.
Mm-hmm. Yeah.
Amazing. I mean, so you'd expect that pediatric emergency physicians would be even better than community emergency physicians at reading chest x-rays.
No, it's all overread. Yeah. And we see it every day. You get a report that such and such is back and they had pneumonia diagnosed yesterday or the day before, and then you actually read the official report and it's all airway disease.
Let's talk about viral testing. Now, I imagine that testing every kid with a cold for COVID, RSV, influenza, and all the rest would cause a full-out collapse of our already crumbling healthcare systems.
Yes.
Which kids do you think require testing for RSV, influenza, COVID? Which kids require testing for RSV, influenza, and COVID?
That's an interesting question. And there's a very variable practice among hospitals about how frequently these tests are done. The wise men at the Choosing Wisely tell us that we should actually minimize this. It's a good rule of thumb to think about you do the test when you think that it could somehow change your subsequent management. So who do you worry about in this subpopulation? So kids that are immunocompromised or that are on various poisons that are compromising their immune system. Patients that have comorbidities, and I think that this is a big one, patients with hemodynamically significant cardiac disease, chronic lung disease, immunodeficiencies, neuromuscular disease, that sort of thing. We see more and more patients with complex care needs at Sick Kids as well, so that would be another group. Patients that are critically ill simply because it's nice to know what you're dealing with. And you mentioned the neonates. That would be another interesting one, especially febrile neonates. And patients that maybe live in shelters or vulnerable settings, that sort of thing. But that, again, is a relatively small subgroup of patients. So the bulk of them don't actually need it because, and families frequently ask us, what is it? Do you do various tests? And is it COVID or is it? And so we tell them, yes, COVID can definitely cause bronchiolitis too. but there is really nothing different that you are going to do about it. Usually I take advantage of the situation and tell them to all get their COVID shots in their family.
Suffice to say that the vast majority of kids that we see in community hospitals across North America, the vast majority will not require viral testing. Exactly. It's really just immunocompromised patients, critically ill patients, newborns, and very atypical presentations. I mean, I find sometimes, harking back to the first question about how do you distinguish these illnesses, we all like to know what's going on and what the cause is. And I think we really do have to step back and think sometimes, are we doing this test just for us, just to know what the exact cause is, or are we really doing it for better patient care? And I think when you ask yourself that question, again, it's not going to make a difference whether the patient has COVID or RSV. If you think that the most likely diagnosis is bronchiolitis, you're going to treat them as bronchiolitis. And I imagine that when they look retrospectively at these kids, it doesn't really make a difference what the virus is.
Exactly. That's a good way of putting it, yes.
As of mid-December, when this podcast was released, there are already more than 300 of your colleagues that have registered for the virtual EM Cases Summit, February 2nd to 4th. You'll get full CME accreditation, a whopping 17.5 M1 credits or their equivalent, the best EM speakers in the world giving cutting-edge talks, having panel discussions, showing state-of-the-art procedural tips and tricks, virtual simulations, symposiums, giveaway prizes, a chance to ask speakers specific questions directly, 3 months digital video package included to watch later for review or if you miss a day, all for the cost of a fancy restaurant meal for 2 or 3 people. Go to emcasessummit.com to grab your tickets before they sell out. The proceeds will go to help ensure that the EM Cases podcast remains free open access for all.
Let's move on to treatment of bronchiolitis. Now, it seems that just about nothing works for bronchiolitis except oxygen in the sickest kids and maybe nasal suctioning. But we often feel we need to do something for these patients in the ED. We had Amy Plint, also a prominent researcher in this area, on EM Cases a few years back discussing epinephrine and steroids for bronchiolitis. There's a few other things that people have tried that it seems like some people will use and some people won't. What does the current evidence tell us about how we should treat these kids who we're pretty sure have bronchiolitis in the ED? And if you could actually particularly comment on the epinephrine steroid issue, because I find that there's practice variation out there. There's some docs who will say there's nothing that works for bronchiolitis except oxygen. And then other ones who say, yeah, but let's try some nasal suctioning. Let's try some epinephrine. Let's try some steroids. And just to make the distinction, this is separate from the kid who you're not sure if they have bronchiolitis or not, and you're giving them a trial of salbutamol to see whether it's bronchiolitis or asthma. So let's just make that distinction first. So again, this is the patient who, let's say you've given them a trial of Ventolin and they haven't improved at all, and now you're pretty sure that it's bronchiolitis. How do we treat these patients in the emergency department?
So with respect to the evidence on various pharmacotherapies, the bottom line is that there is no treatment that has been found to change outcomes. Now, you mentioned the issue about epinephrine and corticosteroids. That is used quite rarely in bronchiolitis. So I should say that North American mentality is very different from treatment, for example, in the United Kingdom or in Australia or New Zealand. Because in those countries, they literally do not use this hardly at all. The rate of pharmacotherapy for bronchiolitis is much, much higher both in Canada and in the US compared to those other countries. So if you have a child who is critically ill with bronchiolitis, I think that it's not unreasonable to try this. But I think that should be an exception rather than a rule. But you asked what we can actually do for these patients, because it's difficult for us as physicians to do nothing. So first of all, I think parental education is a huge component of all this. And it's important to tell the families why the drugs do not work. Also, the profile of the disease. So the fact that this will last another 2 weeks, I usually tell them sometimes 3 weeks. The child is going to go up and down. Some hours are going to be better than others. None of these children feed well. They all feed badly, and they have to be fed every 2 or 3 hours to supplement the hydration. So that's really what they should be focusing on. And in order to feed well, their nose may have to be suctioned before they are fed. Now, the nasal suctioning, which you mentioned, is an interesting thing because there has not been a single study looking at benefit of nasal suctioning in bronchiolitis.
Wow.
Yes.
My understanding was that there was some data, because it seems like for the kid who's not so sync with bronchiolitis, I always hear, oh yeah, nasal suctioning is...
Yeah, so it makes a lot of sense because the children under the age of 6 months, especially when their nose gets plugged up, they do not think of opening their mouth. So they are very nose breathing dependent and they do not feed well. So that is actually a very important barometer in terms of how bad the bronchiolitis is. I'm digressing a little bit here, but that is important because if a child is kind of, huffing and puffing and they're wheezy, but they're feeling like a horse, that child probably does not belong to the hospital. But if they are feeding very badly, that's a different story. So the feeding is important. But no, there is no study. We are actually just finishing an RCT on nasal suctioning in bronchiolitis after discharge. Maybe in 3 months or so, I'll be able to tell you what exactly it does do.
Great. Well, we'll have you back for another EM quick hit.
Yes, the acronym for the trial is called SNOT.
That will be memorable.
Yes, we shall connect in the name of SNOT.
So really, when it comes to the management of bronchiolitis in the emergency department, we know that pharmacotherapy is generally ineffective. There'll be the rare child who receives steroids and epinephrine for bronchiolitis in the emergency department, and that's probably going to be in consultation with your pediatric team in a community hospital. Really, it comes down to 3 things. It's oxygenation, which we're going to talk about in a bit, hydration, and feeding. And so, like I said, we're going to talk about oxygenation in a bit because there's been some fascinating research that you've done on that. The hydration and feeding part, practically speaking, in the emergency department, how should we be doing the hydration and feeding part in the emergency department for these kids with bronchiolitis? And how should we be educating the parents?
So the vast majority of children with bronchiolitis can supplement their fluid intake by their usual route of delivery, which is by oral feeding. So those that are breastfed every 3 hours, we tell the families to feed them every hour or 2, because at each feed, they are going to take less, usually by definition, because of their plugged up nose. So if they are fed more often, it may not be ideal in terms of overall amount, but it's usually sufficient to actually keep them well hydrated. So that's the vast majority of the children.
Simple. Love it.
Exactly. That's it. And it also gives the families something to do, although it can be very labor intensive and frustrating at times.
Yeah, I can imagine.
Yeah.
And then what about for the kids who are sick enough to be admitted? There's IV rehydration, and then there's nasogastric, and that varies across the world. It seems like in North America, it's more IV, and in some other parts of the world, it's more nasogastric. What does the evidence tell us about IV versus nasogastric rehydration or volume repletion in these little kiddies?
So there have been studies on both and comparison of them. And in fact, the evidence is that they are equally good with respect to supplying adequate fluid and also with respect to safety. So you can use either route.
That's a little bit about hydration and feeding. The other part of management of bronchiolitis is oxygenation. Now, we've covered this before on EM Quick Hits with the wonderful educator, Sarah Reed, but it's so important. And this recommendation is based on your research that you've done. It would be great to hear your perspective. So when it comes to oximetry, so monitoring the oxygen saturation for kids with bronchiolitis, I've heard you describe this wonderfully as an expensive babysitter. which is such a great analogy. What has your research shown about monitoring oxygen saturation in kids with bronchiolitis?
Yes, we have come to exhibit a certain degree of devotion to oximetry. We truly, I think, as one of the editors have put it, come to love the shrine of the numbers. And unfortunately, we sometimes behave that way when it comes to oximetry. It's become this so-called fifth vital sign. And the question is the oximetry actually beneficial? And in what context? And when should it be used? So before we get to the research, I think it's important to remember that the main indication for oximetry in bronchiolitis are kids that are in severe respiratory distress. So they have, grunting, nasal flaring, a lot of retractions, horrible feeding, etc. So those are the ones where you really want to know what the saturation is. Or children that need supplemental oxygen, and then they need to be monitored accordingly. There is research on whether we should do a continuous oximetry versus intermittent spot checks. And unless the child is the way I have described, like very ill, the spot checks is the way to go. And this is true of hospitalized patients as well. The reason being is that the outcomes are basically the same. So continuous oximetry then leads to various issues, such as, for example, when the child falls asleep, the oximetry reading is going to drop, which was the case number 1 that you have described at the very beginning of this podcast. As a rule, in kids under the age of 12 months or so, when they fall asleep, their oxygen saturation drops. This is even in healthy children. And in bronchiolitis, it is much more so. They can really desaturate to significant numbers. I'm talking about 75, 85%, that sort of thing, for a number of minutes.
That's fascinating. So could you tell us a little bit specifically about the research on desaturation in normal healthy kids and desaturation in kids with bronchiolitis who aren't admitted to hospital? Because I understand that there's some research that you've done that's actually monitored oxygen saturations of kids at home.
Correct.
So could you tell us a little bit about that? I think it's fascinating.
Tanya Principi, who used to be a fellow at SickKids at the time, she actually did a study where patients with bronchiolitis, they were good enough to be discharged home, went home with oxygen saturation monitors. And these monitors had no alarms and they had no numbers. And the monitoring went on for about the next 24 hours, including during the night. And then the families would ship these monitors to SickKids, and then we would analyze them. What happened is that the patients that have desaturated, and there were about something like 65%, so about 2/3 of the patients have desaturated. And desaturated meant that you had to actually have a saturation below 90% for more than a minute. And we found that not only did many of them desaturate, but quite a few of them desaturated for prolonged periods of time. So something like 10% of the monitoring time, so significant time, to numbers that were like in the 80s, occasionally even in the 70s for brief periods of time. So the bottom line is that had they actually been in hospital at the time, they would have all stayed there for much longer. But because nobody knew, everybody was happy. The main outcome for the study was actually unscheduled medical visits within the next, I think it was 72 hours. And we found that the proportion of those that had experienced this outcome that have desaturated versus not desaturated was exactly the same. They were identical. So it really did not matter.
That is incredible. You've got 2/3 of kids desatting below 90%.
Yes.
Whereas if they're sitting in the emergency department, I get interrupted to come and see this child because they're desatting below 90%.
Yeah,
and this is considered sort of a normal state of affairs for any child with bronchiolitis who's at home, who's well enough to be at home.
Now, most of these desaturations happen during sleep. I think that's key. And the parents were actually supposed to write down when the kid was asleep and when they were awake.
Okay, fair enough. So awake desaturations is a very different thing.
Yes, awake desaturation is a very different, and most of them are sick. If you have a kid with bronchiolitis that's saturating 85%, for example, they are probably not going to be looking well. But if they are asleep, that's a very different story, because when they are awake, they can be at 95%.
That's a bit about what normally happens to oxygen saturations in kids who have low-risk bronchiolitis.
Correct.
And again, the bottom line, if you could just clarify for me, what should we be doing with regards to monitoring the oxygen saturation in the emergency department with these kids? So it sounds like we shouldn't be doing continuous oxygen saturation monitoring. So how do we do it? What do we actually order? Do we say, oxygen saturation Q1H?
It really depends on how sick the kid is. So if the child is obviously very distressed, they have a lot of retractions, they are grunting, they have nasal flaring, they may be dry, moderate to severe bronchiolitis, that child should be on continuous oximetry. So there is a subset of patients that actually do need it. And usually you have made up your mind probably that kid is not going home, because this is not something that's going to resolve in the next hour or two. So yes, so there is a subset of patients that definitely need continuous oximetry. So I'm not saying that nobody in the ED should be getting continuous oximetry, but the vast majority of them have mild bronchiolitis, and those patients may need one oximetry. If you happen to have no oximeter on hand, they may need nothing at all. If they are going to be in your ED for a while, for whatever reason, then those patients should get spot checks. I think it's a good rule of thumb is with vital signs again. So if you decide that patient needs vital signs repeated in 2 hours, for example, then they should get oximetry checked then. And they should be awake. If they are not awake, they should not get a saturation.
Got it. Okay, that's actually really important. So when you put in the order for repeat vital signs in 2 hours, you should clarify awake vital signs. So given that we over-rely on oximetry, how then do we identify the child with bronchiolitis who's at high risk? So again, there's the obvious toxic child, with grunting and all the rest. But what are sort of some of the things that we should be looking for in those patients who it's like, okay, is this patient really high risk? Do they really need to be admitted? Like what are some of the kind of high risk criteria, shall we say, for bronchiolitis?
So I think vital signs is probably number one red flag. So if you have a child with a significant tachypnea, which is to some degree age dependent, but if the respiratory rate is in the 70s and it stays there, that is a red flag. Significant tachycardia, the awake saturation well below 90, especially if it's sustained for a few minutes, that's probably important. The kids that are small and young, so under the age of 2 months, is a fairly risky age group in terms of their ability to compensate for their respiratory demand, because they can become very sick very quickly. The kids that have significant prematurity, generally speaking, under 32 weeks, especially if they are young. So that's important. And comorbidities.
Okay. The same kind of comorbidities we were talking about earlier, neuromuscular disease, immunodeficiencies,
exactly.
chronic lung disease. Okay.
Yes, exactly.
All right. Some people like vital sign sort of cutoffs.
Yes.
Is it fair to say kids, you'd categorize them as high-risk bronchiolitis based on vital signs if the heart rate's greater than 180, respiratory rate 70 to 80 plus?
Exactly.
And then awake saturations persistently less than 90%.
Correct.
Okay. Let's talk about the optimal oxygen treatment strategy for kiddies with bronchiolitis. This was in our case 2. We asked the question, what kind of oxygen strategy do they need? Do they need high flow? High flow nasal cannula seems to be the flavor of the month. And while oximetry can be seen as an expensive babysitter, as you so aptly analogized, I've heard you say that high flow nasal cannula can be your expensive acetaminophen.
I stole that from a publication.
Oh, okay. Is there any great evidence for high flow nasal cannula in bronchiolitis? I mean, when should we pull the trigger on escalating oxygen therapy from regular oxygen by nasal prongs or mask to high-flow nasal cannula in kids with bronchiolitis?
This is a fascinating topic, So just as an aside, I actually had the pleasure of working with Sanjay Mahant from our inpatient pediatric department at SickKids. And he did a study on the trends in admissions to ICU in bronchiolitis over the last, I think it was 15 years or so. And he found that there is a fairly significant rise in the ICU admissions for bronchiolitis without any increase in hospitalizations per se, which makes you wonder, why on earth is this happening? And I'm not sure that we quite figured out as part of that publication exactly why that is, but we also noted that there is a massive increase in the use of high-flow nasal cannula in bronchiolitis. And many hospitals, actually, the children that get high-flow intervention, they go to ICU. So that's just as an introduction to this new wonderful toy that has become very popular in the last decade or so. So you ask, does it actually work? Well, it promises to be a lot, and it's used a lot, but we do not have evidence that it actually does a great deal. So first of all, when should it be used? It should be used on kids that have severe respiratory distress, who are also hypoxic, and they require supplemental oxygen to sustain their saturations above 92% or so, roughly speaking. So they should be distressed and they should be hypoxic, and they should have failed the standard oxygen therapy. So the standard oxygen therapy means the low flow through the usual nasal bronchs or whatever you want to use. If despite of your usual oxygen therapy, they have increasing oxygen requirements, and typically it is, you need FiO2 above 40%, for example, to sustain decent oxygen saturations above 90%. With increasing respiratory distress on your usual oxygen therapy, that's a trigger to think about high flow.
Okay, I just want to review there. So the indications for high-flow nasal cannula in kids with bronchiolitis are a failure of standard low-flow oxygen therapy.
Exactly.
So persistently less than 92% saturations on low-flow therapy, increasing oxygen requirements above 40%, increasing lethargy and respiratory distress, or persistent severe respiratory distress.
That's right. Unless you have a kid that comes in and they are really, really super bad at the beginning. There is an occasional one that comes in that are very, very distressed. You can try and put them on the low flow and see what happens. But if they are really bad, there is an odd one that needs high flow right off the bat. But that's an exception. That's a great exception.
Got it. All right. So that's about the indications. And then the second part of the question is, does it work? And so
yes.
If you could give us kind of a quick summary of the literature out there on the evidence, the evidence for high-flow nasal cannula and bronchiolitis.
Yeah, so there is 2 RCTs, both from Australia. One is a single center study, and the other one is from 17 EDs. So the second one by Dr. Franklin was published in New England, and it's actually quite big. So both of those studies have compared standard oxygen therapy to high flow. And the outcome was escalation of care, which in the standard group basically meant that they went on high flow later, or in the high flow, it meant that they went to ICU and CPAP, et cetera, And the main outcome was the percentage of patients that ended up going to ICU, because the rationale is that the reason you use high flow is to actually prevent the patients ending up in the intensive care unit. And these 2 RCTs actually found exactly the same proportions in both arms going to ICU. So essentially what they have compared is early high flow to rescue high flow. And they found that the 2 interventions produced the same proportion of patients going to ICU. Now, the important thing about this is that in those 2 studies, which were reasonably big, about 70% of the patients needed no escalation of care. And this is largely because of the patients that they have enrolled, because there is no, they did not have enough truly super sick ones. And The high flow nasal cannula costs about 16 times as much as the standard therapy, as the standard equipment. So if you give early high flow, that means that you are actually treating many, many patients that are not going to be benefiting from it at the end of the day at a huge expense. So it's an expensive way of delivering oxygen in patients that may not be benefiting. So the morale of the story here is to use high flow in the rescue scenario if your standard therapy has failed.
Got it. Bottom line is high flow should be reserved for rescue therapy for patients that have failed standard treatment.
Exactly.
That early high flow does not provide any benefit and is just really a waste of money compared to a rescue high flow. That being said, like you had mentioned a bit earlier, the kid who comes in really sick that you're really worried about, you're going to start high flow right away.
If they are very ill, yes. I think that requires a judgment, but absolutely, yes.
Okay, wonderful. So it's interesting in emergency medicine how when there's something new and seems wonderful for other indications, how everyone jumps on the bandwagon and starts using, and high flow is a perfect example, that it is a wonderful tool in other situations. And this is a really good example of how we as a community sort of jump on the bandwagon and start using things before there's really good evidence. So just a reminder out there that it does take several years of research before we know exactly what the indications should be. And high flow is still relatively new. And so far, the evidence would suggest that we are overusing it.
Yes, we are in fact now in the stage of de-implementing high flow, just like we are in the stage of de-implementing other interventions as well. But high flow, I think, is a perfect example of something we should be using less of.
All right, let's move up the oxygen therapy chain a little bit and talk about non-invasive ventilation. Now, this is going to be the very rare child in any given community hospital out there. But I think it's important for that really sick kid that comes in. When would you consider stepping up your oxygen strategy from high flow? So let's say you have started high flow early because the kid's really, really sick. When would you consider stepping up from high flow to non-invasive ventilation?
You have to give the high flow a little bit of time to assess whether or not it is working. So what you are looking for specifically is, first of all, increasing work of breathing. Kids frequently that respond to high flow tend to respond quickly within about 30 minutes or an hour. Their work of breathing goes down. They start feeding and they start looking much more bushy-tailed than before. If they are not bushy-tailed and they are less and less bushy-tailed and they are working harder and harder, that's not good. The other thing is that if you have increasing oxygen requirements, so again, you have to push the amount of oxygen to sustain their saturations at a decent level, that's another red flag. At SickKids, we would call our ICU consultants and we would speak to our respiratory therapy colleagues to think about CPAP. In terms of community setting, I don't think that if your high flow is working, I don't think you need to transfer the child to a tertiary care center.
Okay, that's a very timely question and segues very nicely into the indications for admission to an ICU or transfer to a tertiary care center. And I say timely because currently, we're recording in December 2022 now, there have been huge stresses on resources for pediatric patients. And we really need to think carefully about which kids need to be transferred to a tertiary care center, which kids need to be admitted to hospital, and which kids need a step up in care to the ICU. You know, this is going to be different in different jurisdictions, but generally speaking, which kids require admission to hospital and which kids require ICU admission?
Yeah, this is an interesting point, actually. So you mentioned a while ago the three principles of management, which is the supplemental oxygen, the hydration, and the airway support if necessary. And that's something that we should all be thinking about when we are thinking of admitting these patients to hospital from the ED. Does this child need any of the three? There is, of course, some social considerations, etc. We actually did a study a while ago with our pediatric emergency network colleagues, which included 38 emergency departments around the world with bronchiolitis. And we looked at the kids that were admitted for bronchiolitis and the proportion of those that were admitted that got one of those 3 interventions. And we found that 30% of them did not. So they did not require, we specifically picked these interventions because you have to be in hospital to actually deliver them. 30% of them got none of them. So they got food, they got music, they got tender loving care because they were cute, but they did not get any of those 3 interventions. And I'm not saying that, there may have been some that had to come in nevertheless because they lived on the North Pole or because there were major social issues or something like that. That'll always happen. But 30% is actually a very expensive babysitting. So the indications for hospitalization that you were asking about, so it comes back really to the high-risk criteria, right? So obviously, if the child needs any of those 3 interventions, if they are under the age of 2 months, you should probably have a fairly low threshold, especially if it's a newborn. I think it's more or less a sort of semi-automatic one. But if it's under the age of 2 months, we should be very careful. If the child has comorbidities, unless they have clearly very mild disease, we should be very careful as well. If they have major difficulty feeding, and I think that's a huge barometer really in terms of the need for admission. So even if they are very wheezy and they are tachypneic, but they are kind of happy looking and bushy-tailed and looking around and and feeding well, then they can go home with a good follow-up and the right instructions of when to come back.
Yeah, I mean, I just want to stress there, I'm just thinking with the massive resource problems we're having right now, I wonder whether just simply educating parents really well about feeding and bronchiolitis, which I honestly have been guilty of probably not educating the parents well enough on those kids that I'm sending home with bronchiolitis, as I probably haven't been stressing enough the importance of feeding and how to ensure adequate feeding. So I just want to put that out there as something to not forget to educate parents on their way home, because I imagine, and this is just a guess, it would be an interesting study actually, to see how we could relieve some of our resource challenges just simply by giving really good discharge instructions to parents.
Exactly.
Sorry, that was a little bit of a sidetrack there. I want to get back to indications for hospitalization. It's some of the same themes we've been talking about over and over: comorbidities, poor hydration, vital signs less than 2 months of age. What about for ICU? I imagine that it's in some ICUs, if you're going to the non-invasive ventilation CPAP route, that's an automatic admission to ICU. It's going to be different in different jurisdictions again, but what are the general indications for admission to ICU?
So generally speaking, in bronchiolitis, as you have correctly pointed out, kids that are on high flow, that have actually failed high flow, so the child is having increasing respiratory distress, increasing demand for oxygen to sustain good oxygen saturations, and you are seriously thinking about instituting CPAP, that kind of patients is going to belong to ICU in order to actually carry out the CPAP therapy. That, generally speaking, for bronchiolitis is the indication to go to ICU.
Okay, that's pretty simple. So if a child's requiring CPAP, failing high flow, that's your indication to go to the ICU.
Yes.
Dr. Schuh, this has been an absolute pleasure. I really have enjoyed hearing from someone who's a true world expert and researcher. I can't tell you how much I appreciate, and I'm sure everyone else out there appreciates, the enormous amount of work that you've put into all of your research over the years. And it's especially now important. All the research that you've done on bronchiolitis really has dictated in a way how we should be managing these children in a time of crisis right now in many areas of the world when it comes to pediatric respiratory illness. And so thank you so much. I really hope we can have you back on EM Cases. Maybe we could talk about IV magnesium and asthma sometime, because I understand that there's some fascinating research or lack thereof when it comes to IV magnesium.
Thank you, Anton. It's been a pleasure. I've had a lot of fun during this podcast, and I look forward to our future séjours on other topics.